Super excited to have you all here today. And just want to let you know that this webinar is being recorded and it will be posted to our website after the completion of the 6-part series. Caleb Lewinsky will send the recording and the slides to all participants. So again, thank you all for joining us today for this first webinar in this 6-part telehealth series. We are delighted to partner with Huron for this series and to deliver this very important webinar for today on improving continuity of care with telehealth. I hope you're all doing well and staying warm. If you're in a cold part of the state or the cold part of the U.S., I'm Kim Mayo, and I am a program specialist with the Delta Region Community Health System Development Program, which is providing this webinar today. The Delta Region Community Health System Development Program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. Before we get started on today's webinar, I want to put a plug in for upcoming webinars. As I mentioned, this is a 6-part series. So from the next 5 Thursdays after today, we will have a webinar from 11 to noon Central Time that we will be presenting a telehealth focused webinar. You can see on the screen here the titles that are listed. So next week we will focus on telehealth to support post-acute care. And then on March 4th, we'll be talking about telemental health. And then on March 11th, we will be talking about post-COVID patient transition. And then on the 18th, industry-based telehealth programs. And then to conclude on the March 25th, we'll be talking about analytics to measure telehealth. All right, if we can move to that next slide. If you guys will be sure to mute yourself unless you are speaking. That helps us to cut down the feedback we may have. So feel free to mute yourself at this point. We encourage you to either unmute or utilize the chat box if you do have a question during the discussion, or just you can let us know. We'll be happy. We'd love to hear from you. But please do keep yourself muted unless you do plan to speak. As we get started, you may have seen there's several folks that have already done this. Please find the chat box, type in your name, your title, and your organization. This just helps us to know who's here and helps our presenters just to get a good feel of the audience. All right, now I'd like to introduce our speakers for today. Donna McHale is a part of this team, and she will be joining us for future webinars. Jessica Duke has over 16 years of experience in the healthcare industry and is a registered nurse with extensive experience in patient care management and process improvement. She has a significant experience in telehealth implementation and upgrades, use case design, licensure and credentialing, vendor selection, and project management. She is also a member of the American Telemedicine Association. Her background provides a knowledge basis for quality improvement and quality optimization for multiple specialty practices. She has experience in telehealth projects, including planning, advisory, operational, and functional workflow design, program assessment, and product selection services. Jessica has experience with telehealth maintenance, implementation, and go-live support for American Well, Reach, and Avizia systems. We have a guest speaker with us today, Carrie Gailey. She'll join us a little bit later. Now I'll turn things over to Jessica.
Awesome.
Come in.
Oh, if everybody could just mute their lines. We're hearing a couple extra conversations there. All right, so we'll go to the next slide, please. All right, so looking at our agenda for today, we are going to cover some session learning objectives, cover the telehealth evolution. And we all know that it has definitely changed and shifted with COVID. So we want to kind of run through the timeline with telehealth. I want to touch on the care continuum and how telehealth is a piece of that care continuum. Then we're going to look at some proactive patient population health programs, touch on teleeducation and outreach for patients with comorbidities. I know that was a topic that everybody wanted to talk about. Then we're going to look at digital literacy and barriers, because we know that that's an issue that's coming up with multiple implementations. Then we're going to continue the conversation about teleeducation and look at virtual shared medical appointments as a more specific way to deliver that teleeducation. Then Carrie's going to join us for the conversation. She's got 2 pilot programs that she had with Pop Health Hypertension. Then we're going to switch it over to a Q&A session. So make sure you got plenty of questions because, you know, I have no problem calling on some of my friends that I've had conversations with in the past. And then we'll close it out with some strategies to remain ahead. So we'll go to next slide, please. So talking about our session learning objectives, we want to think creatively about the enterprise approach to telehealth. We want to hear from our experts in the field, like Carrie, and utilizing telehealth for ambulatory care. We want to consider new ways to reach patients across that care continuum, a big piece of the puzzle there. And then we want to network, we want to make new connections and have fun. Looking at everybody's entering the room, I see that we have some new people joining the Delta program. So I'm excited to meet you and hear from what you're doing out there. So we'll go to next slide, Caleb. Awesome. So just some quick housekeeping. So we are going to use the Zoom functions to do some polling and some chat. So at the bottom of it, you'll see the chat capability. So if any questions come up through the slides that we're doing, you can raise your hand and put ask a question. But also Caleb will be putting a poll question out there. It'll pop up on your screen. You'll select choices and then hit submit. That's all it is, but it'll give us a good perspective on where we need to take the conversation. So we'll go to next slide, Caleb. All right, let's get started. So if we think about telehealth evolution, where we started and where we are now, really the basis of the start is with the development of the telephone in 1879. And then in the 1900s, there was this progression that took off with transferring EKGs electronically to Hugo Gemsbach's his development in teledactyl, I think is how you pronounce it. Then in the 1950s, we started to see more progression with teleradiology and then some telepsychiatry, triaging capability. Then the 1960s, this is one of the coolest thing, and this is a plug for Donna because she wanted me to make sure I said this. She said NASA has been using telehealth to monitor the astronauts since the 60s. Of course, NASA was already doing it, right? Then in the 80s, technology became more mobile, right? We had the cell phones. And I don't know if you guys remember that big cell phone that we all carried around and then the bag phone. But then also the computers came out. Apple came out, that big, massive computer. Then the 1990s came around and we really saw this maturity of telehealth and telemedicine. In 1993, the American Telemedicine Association had their debut and their launch. So it started giving us some more guidance to what we were doing in the field. The 2000s started to show the EICU concept in Virginia. That was the first one that was launched. And then even in Arkansas and the Delta, we had the first NICU. So then in 2010, virtual visits and remote patient monitoring certainly gained traction. There was definitely lots of conversation on where we go with this. And then 2020 hit. Telehealth market exploded. And we all know why, COVID-19. Unfortunately, it wasn't the best reason, but it did happen. And everybody's perspective on telehealth changed, it became more of a necessity. So then that takes us to where we are now, unfortunately, thanks to a pandemic. So we'll go next slide, please. So through this whole thing, we've learned that telehealth has a point in the care continuum. There is an access across all pieces of the puzzle in healthcare. We approach telehealth and we think about the different use cases and how they fall across the patient's journey. When patients or consumers initially think about telehealth, they typically think about the sick care or the acute care, like telestroke or EICU. Even post-acute is equally important, and we'll talk more about that next week. But what I really want to focus in on today is ambulatory care, our outpatient telehealth services. This is where we're really focusing in that prevention and the maintenance services of care and healthcare. And then, you know, you're seeing a lot of the primary care, which I know there's a lot of you guys right now that are focusing on that because of COVID really prompted you to go there. But also the community health services, the population health services. And what telehealth technology do you need to deliver this? It could be asynchronous or synchronous. You know, synchronous meaning real-time conversation, or asynchronous where it's a physician or a nurse getting back to you, getting back to the consumer after they've put in that message. So there's different ways we can deliver this type of care. We'll go next slide, please. So it is time to be interactive. We have our first poll question. And so Caleb, if you don't mind popping that up, what I'd like to know, across this care continuum that we've just talked about, where are you currently using telehealth? So if you can just click one of those buttons and then click submit, and we'll give you a few minutes just to click that for me, and then we'll go from there. And also, just as we're waiting for a few minutes, please make sure that you put your name and what organization, your role in your organization in the chat box, because that's our way of keeping track of who is joined the webinar for today. So if you haven't done that yet. All right, Caleb, how are we looking?
Good. It looks like we have a couple more coming in here. I'll give you about another 5 or 6 seconds to answer the question.
Awesome. Hey, Brad. Haven't talked to you in a while. Glad you're on the call.
Yeah, thanks.
All right, that's exactly what I was thinking was going to come out of this. I think ambulatory is definitely the lead right now, particularly in the rural areas, because how do you get the care to the patients that you would normally see on a regular face-to-face basis, right? I think acute and post-acute are starting to pick up speed, particularly as reimbursement has shifted, but ambulatory is kind of the top contender, particularly the way that RHCs and FQHCs have shifted regulatory-wise. So we'll go ahead and shift to the next slide. All right. So as we're talking about proactive population health programs, there's benefits for both the patient and the provider. If you think about the patient's benefit, they're going to have increased access to community health programs that they might not have normally had. We're bridging the gap, right? The care gap that we normally may have had if they hadn't had that continuum of care, and certainly engaging them to kind of take onus for their care or take onus for maybe a chronic disease that they had. The benefit to the provider is certainly a timely delivery of patient information and education, or better coordination of care, and more efficient treatment of that patient. Some examples that we've talked about for pop health programs is that smoking cessation maybe starts as a pilot in the hospital, then pitched out to the community. Even I know there's one hospital that I talked to that we did an assessment on that did an employee-based weight loss program. So they started it with their employees, kind of a benefit to their health. And then they were going to pilot it out to the community. And that always like a good asthma camp. I think it's a great PEDS program that you're pulling in your RTs and then you're pitching it out as a community that's connecting to the community. Technology that is available and needed, you know, it could be as simple as a phone conversation, somebody checking up on these patients, to a two-way video interaction platform. I know a lot of you have purchased this, the technology, but it may not necessarily be needed for these applications if that patient doesn't have it, which leads me to the barriers. Access to technology is still a huge issue. Do they have the mobile device, smartphone? But majority of them do have a telephone. So maybe that's where you start. And then digital literacy. We'll talk about this a little bit more a little later, but the lack of technology skills and know-how is still a huge issue. And, you know, language interpreting issues. So we'll go to the next slide. I think we have, this is our chat question. So down at the bottom of the screen, you see your chat. This is where you plugged in your name and your role in your hospital. I want to pose this question to you. What are your biggest pain points with teleeducation or pop health programs? You know, this could be getting them launched. This could be maintaining them. What are you finding are your biggest pain points? Provider buy-in. Thanks, Pam, for that. Just getting started, Mary Williams said that. Engagement. Now, C. Scott, is that engagement from the consumer, or is that or is that engagement from like C-suite buy-in? Give me a little bit more on engagement. Yeah, certainly reimbursement. Rusty said availability of high-speed internet and service. Lisa, reimbursement. Absolutely. Yeah, reimbursement. It is improving, but there's still a lot of work to be done. Let's be honest. Yeah, so the engagement was providers. Yeah, I definitely think that's a continual piece of it. I do think there's improvement though. I mean, we think about it from just the PCP visits and how that has improved. I think that if we start migrating into pop health, that there is an ability to get that. Nathan from Marshall Browning said technical ability of the older population. Yeah, that's that digital literacy. Absolutely. And Amy, she said getting started, modality, giving it a fair trial. And then Jean from Savoie said agree with lack of broadband infrastructure. Yeah, it's funny. That's the conversation that I'm going to bring up next week. I think that's access to technology and digital literacy are things that we have to recognize. It's very much present in our rural areas, and we have to have a good plan on how we're going to approach those areas. Thank you all for your comment here. This is very helpful. So then my next question is, where do you see potential program successes? Is the thought, where do you see a program to implement? Where do you see your need within the community? Oh, this is Joanne. She said not considered a face-to-face encounter in RHC. So Joanne, I assume you mean the pop health programs are not considered face-to-face in RHCs?
The telehealth visits are not considered an encounter.
Got it.
So it doesn't add to your count towards your productivity.
Okay, that's where I think you're.
Service.
Yeah, that's another part of that whole policy change that needs to occur. So Mary Williams said chronic disease management, better control of chronic disease. Totally agree with you. There's programs, and I think I talk about on the next slide about chronic disease self-management through teleeducation. Oh, I missed one. Success behavioral diabetic education. More convenient and better services.
Come on, I just got a thing, meeting going.
And then specialty clinic for RHCs, a specialty clinic for pop health. Jean, is that where you're going with that? Anybody else have any other thoughts on potential programs? Oh, okay. Amy said reducing readmissions through chronic disease management. And yeah, absolutely. Totally agree with you. I think it's taking a proactive approach to all of these, the chronic disease management, taking a proactive approach to population health is the bottom line, and wherever your population needs that approach is how we have to focus in. Behavioral health services, that is a continual need. I totally agree with you, Julie. So program successes, this is from Judy. Telehealth for remote monitoring of home health patients. Health. Absolutely. I have to say, Judy, you've had some great examples of that at your facility. Reduced travel for TBS to larger facilities 100+ miles away. Yeah, absolutely, Pam. Completely agree. And Jean said, yes, follow up to telestroke acute to post-acute management, for example. Oh yeah, Jean, I like that. That's great. The follow-up care for telestroke. Absolutely. So that could be a transferred patient or maintained at your facility in Savoie. This is great. Well, we're definitely just feedback. We're taking notes from this because I think you guys have some great ideas. And as we do some follow-up calls, I'd like to continue this conversation because I think you guys have some great thoughts, and it's where we connect the dots. So Caleb, let's move on to the next slide. They did put me on a time limit. Y'all know I can talk about this stuff forever. So teleeducation, when we think about this, we think about the patient benefits because it's enhancing access to educational materials. And then, you're proving the patient outcomes if you give them the education. It's better communication with the provider. You can reach those goals that the provider is setting with that patient. You know, the most important thing that I get out of this is you're giving them the confidence to manage their chronic disease or their condition, really. The benefit to the provider is, once again, that timely delivery and that coordination of care. And then there's also the thought that you could reduce readmissions because you're giving them the education on how to manage the disease better or condition. So some examples here, this is what I touched on a minute ago, was that chronic disease self-management program. So if you're educating them on how like the activities of daily living need to be, then they'll be more apt to manage their self-care. Other examples are like a diabetes prevention, even the pre-op surgical education. So if you do this via telehealth, you give them the education to prep them for their surgical encounter, then you're preparing that patient better. Some technology, once again, we talked about it, your two-way audio video, you have your verbal audio only communication, even there's some remote patient monitoring with medical devices application here. And the barriers continue the same. It's access to that technology and the digital literacy, as well as language. All right, I think we can go to next slide.
Hello. Yes, it is.
All right, and just a reminder, if you can mute your lines, because I think we can hear some telephone conversations. So thinking about telehealth education, there's an application called virtually shared medical appointments. Now, if you think about the traditional medical appointment for a chronic care patient, they are brought in one by one to see the provider. If you think about it, during 2020, there was the need for PPE. There's lots of restrictions and a heavy weight on that provider office. If you think about the shared medical appointments, the patient can then be seen in a virtual group setting. So you're managing more patients at a larger scale, so like 8 to 10 patients, right? The home environment can be shared virtually. So then there's some issues from there that you can address those challenges. And then the best part is there's no PPE required in the home setting. So then there's a lot more assessment for the verbal and nonverbal cues from the patient. So the benefits of the VSMA is the efficiency and improved outcomes of the patient. Plus the practitioner is practicing at the top of their license, and there's broader management of chronic illness. And really, there's a cost savings component of this because you're seeing that 8 to 10 patients at one time. It's a great application. So we'll go to the next slide, please. So as I touched on earlier, digital literacy. You know, when we think about digital literacy, it's defined as an individual's ability to either find, evaluate, or even compose clear information through the writing or the media on various digital platforms. So this could be on the internet, it could be through a telehealth website, whatever it may be. So as we look at my house here, the basis of this is access. So is access through the opportunity, or is it through the competence? And then when we build up from there, we think about use. You know, under innovation, is it the navigation skills or access skills? Or is it the critical thinking or creative thinking skills that are the multitasking or input and output and tools and tech skills? As we build up further and we gain our digital literacy, we think about how to create and understand. So the innovation piece of it is focusing on the rights and the responsibilities, the pooled knowledge, the judgment, even the safety and security. And then under critical and creative thinking, we're focusing on the cultural empowerment of the individual, citizenship, the creativity. So all these pillars are building up to what creates a solid digital literacy. And I think this is something that we need to build into programs as we develop a high-tech program like telehealth. So we'll go to the next slide. Here's some facts that I thought were really interesting. There was a study that was published by Harvard University that found people who had at least 12 years of education had a lifespan a year and a half longer than people that had less education. Isn't that crazy to think about? And that's just 12 years of education. Now, this one's interesting too. $232 billion are spent each year in healthcare costs related to the inability to read or understand health information. That's crazy. Wouldn't you rather spend that $232 billion increasing broadband access? Maybe I'm only thinking about telehealth. And then 21% of adults in the United States are illiterate or function in an illiterate category. 21% of adults. You know, also I thought very interestingly, the low literacy. So it's being linked to prevention services, delayed diagnosis, and adherence to medical instructions. And think about that. If a patient can't understand their discharge instructions, how are they going to adhere to them? That's where part of our patients that are non-compliant are coming from, is because they can't even understand what their discharge instructions are. 2/3 of fourth graders read below grade level, 2/3. And then the same number of graduates from high school still reading below grade level. So 2/3 of graduates are reading below grade level. So I think the bottom line here is that for us to improve health communications, it would give us a reduction in healthcare costs and increase health quality. So I really enjoyed this slide. We'll go to the next slide, please. All right, so I'm going to turn it over to Kim so we can introduce Carrie.
All right, Carrie, we're so excited to have you with us. Carrie Gailey is a clinician, mother, wife, and patient advocate. She is currently a postdoctoral fellow in leadership at Case Western Reserve University, where she received her doctorate of nursing practice in 2014 and a Master of Science in Nursing in 1997. After completing a 2-year National Quality Improvement Program in 2015 as a VA Quality Scholar, she participated in a multi-site quality improvement program and facilitated the development of a resident quality improvement coaching toolkit. Her current position is in distance health at the Cleveland Clinic, where she is practicing telemedicine, designing population health programs, integrating digital tools, and developing quality and distance health. Dr. Gailey has been awarded an AMA grant in innovations in medical education, designing an interdisciplinary elective in telehealth for medical students, residents, fellows, and advanced practice providers. Partnering with the Cleveland Clinic's Office of Patient Experience, the team created a repository of training materials for providers and patients. She is also a clinical assistant professor at University of Illinois, Chicago, and the Patient Safety Leadership Program, a patient-centered outcomes research institute, clinical effectiveness and decision science advisory panelist, and has consulted for the American Academy of Pediatrics in quality and performance improvement in telehealth. So Carrie, we're so excited to have you with us. Feel free to take it away.
Thank you very much for allowing me to be here. It is definitely an honor. I really wanted to take this opportunity to tell you a little bit about 2 programs that we initially developed. They were pilot programs, but the wealth of information that we learned, I'm hoping that I can share with you and might help your journey in telehealth. So next slide, please. So really, the first pilot we did in population health and in ambulatory care was around hypertension. The pilot was really identified to understand the pitfalls, what type of infrastructure we need, and to look at the feasibility of using virtual visits in primary care and integrating remote patient monitoring devices. In this specific instance, it was a blood pressure cuff. And then we also wanted to see, was this a satisfactory way of providing care to providers and also to patients? To put it into perspective, this was about 2016, 2017 that we actually did this pilot. So it was somewhat more barriers, but COVID hadn't hit, so providers were not near as familiar as they are now. And so what we really found in the providers is we wanted to be able to trace the identification of providers, onboarding providers to be able to do the pilot, and establish workflows and diagrams that may be able to be sustainable for our projects and scalable as we went to going from a project of having 100 patients with 10 providers and thinking about that, we have hundreds of providers in family medicine and internal medicine, and how do we scale that? And really making sure that we satisfy the needs of our patients, encourage them to be more self-management and modify their lifestyle, and with the bottom line goal of improving the outcome. And these were patients, 100 of them, as I said, that had uncontrolled blood pressure, that were rising risk. And so what we did is we identified the patients, and we had some help from Optum, easily had a conversation with our providers afterwards. They could have been identified and picked out from patients in the office. So these were patients that were not surprising to the providers that were onboarded. The providers were selected by the fact that they had expressed some interest in telehealth, and we assured them that we would guide them and support them with our team to be able to do this. And once we got a list of the patients, we created some scripts for patients for the office to orient them. And it was a 6-month project where we asked the patients to take their blood pressure twice a day with a Bluetooth-enabled device. And the readings would go to an external website for our vendor that was monitoring that, and it would have dashboards. And then I was the coordinator of the program and the designer of the program, and then we had care coaches to help with the lifestyle management. And the provider pool, the physicians, were all able to see patients virtually. So there's a lot going on in a very small pilot. But what we figured out, and I think is probably the jewels of anything in this program, were the pain points, the lessons learned, and the ability we had to change our system, change our way of thinking in our providers, and meet patient needs. So I just want to run through some of the pain points that we identified and how we learned from them moving forward. So some of the pain points were time, trying to set up the project, to think of everything that we really needed to. And I think the biggest lesson learned was that you just jump in and you have to modify as you go. Some of it was communication strategies. How are we going to best make sure that we get the information to the providers? How often do they need information about their patients? What was the escalation process to get back in touch with the providers' offices? The particular was, I think, the highlight of anything that I could say is getting the information integrated into our electronic medical record. As I said previously, we used an external vendor. The blood pressures would all go to an external site, which means that the provider had to click out of their electronic medical record to a different site to be able to see the information. And that just obviously was not feasible or sustainable in the long run. Some of the other office-specific challenges we had were in regard to staff turnover and making sure that everybody was aware of a program, so that if a patient called the office, they were getting information that was accurate, and it wasn't frustrating to the care team themselves. And again, I think you guys hit it significantly again, was the confidence in the skills for doing digital visits, both on the provider end and then what the patients brought to the visits, and the providers becoming very frustrated of understanding how best to address the patient's challenges. Distribution of the devices was a bit of a challenge. We had an external vendor who sent them to the patient's home and then made sure to pair the devices to go to be able to go into their external site. Providers, the patients didn't realize who they were calling. The area codes were different, so this was a bit of a challenge. And again, if they called back the vendor, they didn't know about how to get in hold with the physician or the care team, so it became a little bit cloudy. It all surfaces keeping it in-house, integrating into the electronic medical record, and really being able to focus on that is critical. So the lessons learned, and I want to really highlight some of these and drill down a little bit deeper, is Selection of patients can be done at different points in time. We specifically did it all up front, but we also integrated that we had a rolling onboarding session. And this can easily be done in the office setting, whether it's for hypertension, congestive heart failure, diabetes, or any of the chronic illnesses, or even with multimorbid patients. We really had a clear profile, and it became clearer afterwards as to who would be eligible for this first pilot and who would not be, and making sure that everybody knew about that, to help make sure that we asked the appropriate questions. Bringing everything in-house and not having an external site was hugely important. And that was probably the first thing that we did after the pilot. Orientation manuals, and this would have to be electronically and something that we could mail out to the patients. Again, looking at, I think somebody mentioned before that they had some challenges with getting information to the patients. And this is what we wanted to do, is they can see them electronically, but we noticed our patients didn't have the ability to maybe look at the patient portal that we sent things through, but printing them out, and they didn't have a printer, so we had to do that for them. And so we tailored things specific to the patient preference and the patient need and how they wanted it. The distribution of devices is critical. We've subsequently learned many ways to get different devices to them, even from distributing them at the office setting themselves. Providing on-site IT support, and really it doesn't have to be very fancy or eloquent. It was more of somebody of a digital navigator, a champion within the office to help that patient navigate the system if they had questions about how the device was or wasn't working. We also were able to assure with that one-on-one person that the readings were more accurate, that the cuff size was appropriate, and they really understood the entire program. So that's a lot on this slide, and like Jess, I could probably talk for an hour about this program specifically, but it was very, very helpful to us to help us create the infrastructure, to create it so that we were able to use this for the rest of the system as we expanded. So the next slide. Thank you. So we really wanted to kind of recap the programs themselves, and really what we wanted to do is look at feasibility, satisfaction, and patient engagement too. So the feasibility of remote monitoring, we ended up shooting for 100 patients. We had 81 that completed the program. And the reason I think that they did not complete the program was because they were traveling and they weren't sure if they could take the devices, which was another communication challenge that I alluded to. The other was that we saw a reduction in their blood pressure. So those people that were uncontrolled, we really brought their systolic down by 7.4 points in the 6 months, and we decreased their diastolic, which was significant. The key factor that I think is most important is the coaching, that lifestyle management, that teleeducation is imperative to do this together. And I think this aligns with what Jess shared about shared medical appointments, virtual shared medical appointments. Instead of repeating the same thing over and over again, can you bring this all together? Can we set goals for our patients and lifestyle? Because we found within 5 weeks, and we've repeated this in subsequent studies, that their blood pressure was better in control. And in our specific pilot, if they had attended 5 sessions, their blood pressure was still in control. I stopped looking after about 18 months, a year and a half out, which I thought was tremendous. We were able to adjust medications very readily. It was more in real time. We didn't have to wait for the patient to make an appointment. The providers were up to date. We had one provider who said, boy, I haven't had my patient in control in 6 years, so this program is amazing. So having those initial people that were excited about the program and willing to try to spread that to the rest of the providers was huge. And so really looking at how to sustain those programs. From the first project, about a year and a half later, we ended up doing a second pilot, which again created a lot of other information that we subsequently rolled into our programs as a whole. And that was one of the specific family health centers we had collaborated with Best Buy. So we went out and found a vendor, wanted to partner with them. It was an unusual vendor, but it worked really well for us. And they actually agreed to support the program. They would help train the IT, the group patients on the actual devices themselves. They sat in the lobby. And this one was specific to newly diagnosed patients, making sure they didn't have white coat, and managing their medications. And over 200 patients enrolled in this program. It ended up running, they would take their blood pressures continuously until they were brought back into control, so that at that point in time, we could bring them into the office rather than having them not have a problem. And the longest person lasted in the program about 3 months. But the outcome of that one is we saw within a 7-week time frame, at this point in time, we had everything streaming into the electronic medical record. We had much better communication tools. Patients were onboarded better. Offices were more aware. And the systolics were decreased with 6.3 points within 7 weeks, which was huge. And as I said, subsequently, we built upon everything. We shared our knowledge so that we've not only made a patient-centered medical home, but we've considered it more, and we brought in the subspecialists also. So in hypertension, we have preventative cardiology on board and nephrology partnering with us to make our programs more robust and more appropriate for our patients. So that's a little bit about the pilot. I'm looking forward to answering any questions a little bit later on. So that's next one.
Awesome. Great. Thanks, Carrie. I think we're going to go into the QA session right now. Kim, I kind of am talking to Rio. I'm sorry. So
That's great. Feel free to just, if you have questions, I see one in the chat we'll get to. But yeah, if there's, if you guys have questions, feel free to, or comments or thoughts, feel free to unmute or type in the chat, and would be happy to dialogue, because, if not, Jess will probably call on you. So.
I was thinking we could go ahead and start with Michelle Meyer's question. And Carrie, I'm wondering if you might be best to answer this one. She said CHC critical access hospitals are fragile to begin with. With all the system issues in RHCs, there is a carve out of the time since non-allowable. Therefore, hurts next year AIR. How can you afford devices, navigate, etc.?
So I think one of the things that we learned is some of the devices are not considered medical devices, they're not paid for, and so Bluetooth enabled was not something that we could use. However, many of the patients, at least in hypertension, they had some of these devices at home. They may have had a 10-year-old blood pressure cuff, but it was still working. We made them bring it into the office, assure that they're getting accurate readings, they were putting it on correctly, etc., which is a whole separate challenge we identified. But then we could support them from our electronic medical record to the patient portal to actually upload their blood pressure readings over time. And we were very fortunate to have somebody then be able to graphically display those for us if they didn't. And if not, it's pretty easy to scan them. We were also thinking of some low-tech issues, even lower than that, when COVID hit for the patients who didn't know how to interact with flowcharts or hadn't had that experience. And what they've been able to do is just take pictures with their phone, and they actually texted them to the office that way. I think that answers your question. Does that make it, is there another component that I missed?
And Michelle, feel free to come off of mute.
Yeah. I just, we're kind of in a quandary. I think, there's so many, I agree with all the variables that everyone talks, the deterrence, between broadband, between the reimbursement. I guess I was trying to think of, the navigator, all the extra time and not getting an RHC rate that we do today. You don't get that same reimbursement, in my understanding. So, and I saw that you almost doubled, let's say, productivity. I don't know if you're making it up in volume, some of the money, but you still don't get the carve out. So I'm still, struggling with how to make this work, or even seeing it, even if we were able to do it with broadband, with the literacy. I mean, there's a lot of uphill battles here in rural America, I think, and RHCs.
Oh, I totally agree with you. I think there are. And I think there, like we've talked about before, the policy is the part that really is the biggest uphill battle. And it's deciding, and I think this is a debate that we've had with multiple sites is, do you continue the forefront in caring for the patient to think about the wraparound services that are going to come into your system, as opposed to the reimbursement at that time, particularly for a pop health program? Does that make sense?
I think it would, it can. I wish there was some of my financial folks here weighing in on the options here, as well as my clinic. I mean, I think it's so hard, even with doing wellnesses today with that wraparound services. I do agree with, the wellness is the population health, but we struggle with that even to get compliance, or, because unfortunately, I hate to say it, there's no stake in the game for the patient. If you can advocate for the MAM, you can advocate for the colonoscopy for colon cancer, you can advocate for PSA, sleep apnea, but how do you get, it's the compliance of following through, I guess, for that wraparound. And then
Jessica, this is Amy at Marshall Browning.
Amy.
I just want to respectfully put out here that you've got to start thinking like a con artist. Are you in it for the short con or the long con? Short-term reimbursement is a thing that's going to be going away for all of us very soon. Our hospital just joined an ACO, and so looking at quality of care, reducing Medicare spend, overall population health is becoming increasingly important for all of us. And it's not going to be too terribly long before every cause backed into that same corner. So we really have to stop being short-sighted and looking only at immediate reimbursement, and start looking at this with a building mindset. That's just my opinion.
Amy, it's Gary. I just wanted to actually say that was probably one of the key drivers that facilitated our move. Is it aligned with our primary care that was thinking population health, but really we've gone in 2016, 2017 to when we started, to the most of our primary care has gone and is caring for ACOs. And so that has really, by having that infrastructure shift and planting a flag, has allowed us to be able to be a little bit more successful in today's changes that have occurred.
Absolutely. I really appreciate the dialogue, you guys. This is exactly what we wanted to happen. Anybody else want to come off mute, ask questions, any other thoughts with this subject? Because this is something that constantly comes up. I'm going to go to the list here in a minute and pick a name. Okay. Nobody's taking the bait here. So let's see here. Who is doing, I know ambulatory care wise, Marshall Browning, I know you guys were doing some primary care. Anybody from there want to talk to your pain points or successes? And silence.
Most of our pain points are, this is just my perspective because I work mostly on the inpatient side, but just getting everyone comfortable with it. And, a lot of our older patients don't have, they're still walking around with Motorola flip phone, so there's not a smartphone there. I know that on the inpatient side, we've been doing a lot by telephone as far as transitional care. And we're starting, we've got a new care coordinator that's going to bridge the clinics and the hospital side.
Awesome.
So I'm really kind of excited because we are looking at building this up. When you were talking about the shared virtual appointment, my brain just went all over the places on all of the classes we could do. And, we've been over a year now. We used to host lunch and learns for the community all the time. And, this might not be something that is immediately reimbursable to us, but we can build on this if we can improve the health of our community at large. And like I said, reduce that Medicare spend. That's the end goal. I mean, that's the name of the game. That's, quality and cost savings. That's what we have to focus on. I've been, the chatterbox of the group for most of the time, but Brooke has more experience with dealing with the primary care providers, and I don't know if Sarah's on here or not for the specialty docs, but I know we have a few that are using those.
Yeah. And we helped you guys do that workflow and the policy and procedures for the primary care and specialty care clinic. So, I mean, I think you guys are definitely positioned to be successful for sure. We did have a question come in from Cassie Scott. Cassie, do you mind coming off mute?
Hi.
Hey, Cassie.
Hey. Yeah, I was just wondering if anybody had any examples of how to include positioning for an economy of scale.
Can you give a little more detail to your question on the economy of scale?
Well, I think after listening to the last few conversations, I might have kind of answered my own question anyways. So I think I might be okay.
Okay.
Yeah.
Do you want to tell us the answer that you came up with, just because somebody else might be thinking the same thing?
I think if we do more, if we just concentrate on trying to push more like preventative care and look at the long-term goals, then reduction in hospital costs.
Absolutely. Totally agree with you. I think that that's kind of the thought process on some of the pop health programs, is keeping the patient out of the hospital because the expense of a readmission is so much bigger. Yeah, at least that's what I have found in the success of it. Carrie, do you have any thoughts there?
No, and actually that's where the biggest one that we tackled this year was looking at congestive heart failure and at hypertension from a readmissions perspective. Those people that were frequently readmitted or for any of those chronic diseases or anything else. And we looked at transitional care coordinators along with the chronic care, and how could we partner together to create it so that there was better communication, better focus on those particular populations. We had already created some structures in place, as I said, if they didn't have a device or they couldn't pay for it, or if they only had a flip phone, how do you get that information to that patient? And really, some of it is shifting in design of who does what on the care team. And what I mean by that is the providers currently now are the ones probably talking about lifestyle management and behaviors. And so, for instance, what is your physical activity? Now, are you eating well? Are you following your renal diet? Are you doing all of these things? Smoking cessation. And so what we did is we kind of shifted it so that they didn't have to take the time out of their day to do it. Who could do what parts of this care process with the patient? And it was really being able to redesign the care team. And then from the patient perspective is really understanding really what matters to the patient so that we're addressing those, and then creating, you know, some small goals is how can you achieve it to get that win that they get excited about and that they're successful with. So one of the things that I did when I was doing pediatric weight management was patients, whether they had a phone that they could show me or not, is they walk through what's in their refrigerator, what's in their pantry. How could you possibly change that? Where's your space to exercise? And so what we did is we built a rapport so it really made them personalized care, but allowed them to do it through video connection. And I shared with Jess before, and one of the reasons I think that I got so excited about telemedicine is not because I'm technologically savvy, but because I was getting truancy letters from my kids' school as to why were they missing so much school to come see me. And I'm going, that's not their job in life. Their job in life is to go to be school and to build relationships and have fun, not to come for weight management that took them 3.5 hours, 4 hours to drive to come and see me.
Awesome. All right. Well, any other questions? Anybody have any last minute questions? Okay. Well, I think we can probably go to the next slide, Caleb. So strategies to remain, oh,
Keep going.
did somebody say something? Okay. Anyway, strategies to remain ahead. So we want to be forward thinking in our strategy. We want to think about developing initiatives to move telehealth across the care continuum. We need to understand the population health and the distresses related to those the populations in our communities, and then focus in on how to change the healthcare for them. And then provide recommendations back to the organization for best practices for that community-based telehealth solution. And then if you want to think beyond the current solution, to really push the boundaries, push the limits outside of the typical telehealth that we talked about earlier, you know, push it beyond telestroke, push it beyond the telepediatric capabilities. And then think about how can you utilize remote patient devices? And then start discovering new possibilities with your telehealth applications. And this could be within the community for the schools or even the business, the industrial based telehealth programs. So next slide. All right, so our key session takeaways. Constantly, telehealth is evolving. Patients are acting like consumers. They're using technology more and more to gather the information and meeting their healthcare needs and preferences. Telehealth is an enterprise initiative across the care continuum. And we need to use the lessons learned from our peers like Carrie about how they use telehealth to support the patient population. And then we need to review the strategies to remain ahead with our leaders. So next slide. So here's our contact information. If you have any questions, if you think of something after this, please let me know and we can continue the conversation. You know, I would love to. And with that being said, just want to thank you all for attending, and I look forward to the conversation next Thursday. And I think that's the next slide, Caleb. We are going to talk about expanding telehealth to support post-acute care. Don and I will be presenting on the care continuum, but more focused in on post-acute. We're presenting a couple use cases, focusing in that post-acute. And then we also have a guest speaker, Mark Saxon, who will be focusing on complex chronic care. So I think that next slide, Caleb. Yep, that's it. Okay. All right, guys. Thank you all so much.
Yes, thank you, Jess and Carrie, for sharing such great information. We just appreciate you guys so much. Thanks everybody for joining us. We appreciate the dialogue and the feedback and the questions. So you can just expect more of that for the next 5 weeks. So we hope to see you next week, if not before. And we're so glad that you joined us today, and we'll see you soon. Thanks, guys.